Next speaker is Fumihiko Miura. He presents flowchart of the management of acute cholangitis.
It's a great honor to be able to speak to you today. I'd like to talk about flowchart for the management of acute cholangitis. This slide shows the basic concept of severity grading of Tokyo guidelines. For grade 1 mild acute cholangitis, initial medical treatment may be sufficient. Biliary drainage is required for grade 2 moderate cases, and organ support in addition to biliary drainage is necessary for grade 3 severe cases. This is a flowchart of TG13. The flowchart indicates the recommended treatment strategy according to the severity grading. The flowchart was established based on the evidence and consensus. For mild cases, initial medical treatment, including antimicrobial therapy, may be sufficient in most cases. Treatment for etiology may be performed after pre-interventional workup. For non-responders to initial medical treatment, biliary drainage should be considered. Treatment for etiology might be performed simultaneously, if possible, with biliary drainage. This table is a result of Japan and Taiwan collaborative study. 30-day mortalities were not significantly different according to timing or absence of biliary drainage. Based on this result and the actual status of clinical practice, we decided not to revise the flowchart for mild cholangitis. For moderate cases, early biliary drainage should be performed. Treatment for etiology should be performed after the patient's general condition has improved and following pre-interventional workup. According to the Japan and Taiwan collaborative study, 30-day mortalities were significantly lower in patients with moderate cholangitis who had undergone biliary drainage within 24 hours and 48 hours than in those after 24 hours and 48 hours, respectively. There were two comparative studies between urgent and elective endoscopic stone extraction for mild to moderate acute cholangitis due to choledocholithiasis. There were 0 mortalities in 2 studies. Incidence of post-ERCP complication was significantly higher in urgent group in one RCT, while length of stay was significantly shorter in urgent group in another study. Based on these results and actual status of clinical practice, we decided to revise the flowchart for moderate cholangitis. In the revised flowchart, we added a red arrow and statement. Treatment for etiology might be performed simultaneously if possible with biliary drainage. For severe cases, appropriate organ support for acute organ injury is necessary. When patients were stabilized with initial medical treatment and organ support, urgent biliary drainage should be performed. Treatment for etiology should be considered once the acute illness has resolved. This slide shows the result of Japan and Taiwan collaborative study. Although mortality rates were not significantly different according to the timing or absence of biliary drainage, mortality rates of severe cholangitis were high, about several percent. This result indicates that urgent biliary drainage with organ support is mandatory for severe cholangitis. Then we decided not to revise the flowchart for severe cholangitis. This is the updated TG18 flowchart for the management of acute cholangitis. The modification is only 1 point, as shown by a red arrow. For moderate cholangitis, treatment for etiology might be performed simultaneously, if possible, with biliary drainage.
Okay, now we have questions.フローチャート、こっち、室瀬先生、フローチャートです。全体のやつですかね。
モデレートです。
Yes. In moderate cholangitis cases, do you agree to perform treatment for etiology simultaneously, if possible, with biliary drainage for moderate cholangitis? So in moderate cholangitis cases, if it is possible, you move also stones. Okay. One is strongly agree, two is agree, three neutral, four disagree, five strong disagree. Please vote. Okay, thank you. Okay. And next. And next one is question 2. Do you agree to revise flowchart for the management of acute cholangitis? So whole body of flowchart. 1, strong agree, 2, agree, 3, neutral, 4, disagree, 5, strong disagree. Okay, please vote. Okay, thank you. And next one. And this is a little bit, no, next one. Okay.
According to the TG13, a treatment strategy for patients with both acute cholangitis and cholecystitis should be determined in consideration of the severity of those diseases and surgical risk in patients. There has been controversy about the treatment for patients with acute cholecystitis and choledochorichiasis. We want to know current status of clinical practice about the treatment for such patients.
So this is very difficult cases. If patients have acute mild cholecystitis with choledochorichiasis, one endoscopic lithotomy and subsequent laparoscopic cholecystectomy. 2, early laparoscopic cholecystectomy and subsequent endoscopic lithotomy. 3, early laparoscopic cholecystectomy and simultaneously common bile duct exploration. You can see the slide. And 4, early laparoscopic cholecystectomy and intraoperative endoscopic lithotomy. 5, other treatment. Yes, Dr. Strasberg.
I think before we ask the question, we need to define what we mean by delayed laparoscopic cholecystectomy. That could mean the next day, or it could mean 12 weeks later.
For mild, so early laparoscopic cholecystectomy.
Early.
Mild case.
Okay.
So number 1, delayed means about a few days, in a few days.
Right, okay.
1 or 2 days. Okay. Okay, so please vote 1 to 5. 5 is others. Okay, 60. Okay, thank you very much.
I want to go back for a minute to the flow chart and talk about the grade 3. And the point I want to make is that there has been a lot of literature in the last few years about management of sepsis. And we talk here just about general supportive care or organ support. And I wonder if we should be a little more specific The critical care people have the Surviving Sepsis campaign, and not that we have to create that, but that we could endorse that as part of what we think should be done for the patients with severe sepsis. What does everyone think?
We think we should follow the sepsis guidelines.
Yes, we should say that.
Yes.
Do others agree with that concept?
Yes.
A lot of heads shaking yes, up and down.
Okay.
That would be easy to just refer to it.
Yes. Is there any comment or questions? Okay, so move next.
Thank you very much for your kind attention.